Hello, Lord. How are you?
Hello, how are you? Thank
Is
you.
okay?
I'm okay.
Hi, Mr. Lock. Good
Hi,
afternoon.
Good.
Hello.
Thank you. How are you?
Hello, good
Hi,
afternoon.
thank you. Hi, Pichi.
Hi, BG.
Richie, your mic is muted.
Okay, I will now start the
Sounds
program.
okay.
Yeah.
Okay, a very warm welcome to each and one of you from Asia and to all our audiences from all parts of the world, most especially to everyone in Palestine. This is CPD Asia, the online continuing professional development platform for Asian Radiologic Technology Societies. And hosting the 41st CPD Asia is the Palestinian Association of Medical Radiation Technologists, PAMRT. And I'm Peach Luna, the CPD Secretary General and your program host. We are live streaming on YouTube. You can search MSR or PARI and or the VART channel. So you can join us live or you can watch a replay. So as we start now, please welcome, I call in the President of Palestinian Association of Medical Radiation Technologists, PAMRT, Mr. Mohammed Abdel Ghani, to give us a welcome message. President Abdel Ghani.
Ladies and gentlemen, esteemed colleagues, this is Mohammed Abdel Ghani, President of the Palestinian Association of Medical Radiation Technologists, PAMR. Good morning and welcome to the 41st CPD ASA conference. It is my great honor to welcome you all. We are thrilled to host this conference and grateful for your participation from various Asian radiographer societies. Your presence highlights our shared commitment to advancing our field through continuing education. In Palestine, despite facing significant challenges, we remain dedicated to maintaining high standards of medical radiation technology. Our effort to provide quality education and training are unwavering, even under difficult conditions. This conference is a valuable opportunity for us to learn from each other, exchange ideas, and enhance our professional skills. I encourage you all to fully engage in this session and workshop. Thank you for joining us, and I wish you an inspiring and a productive conference. Thank you and welcome.
Thank you so much for that warm welcome, President Mohammed Abdel Ghani of PAMRT. You know, this CPD Asia is highly supported and graced by member societies, the presidents, all the officers, and their representatives. So let us greet and welcome President Fernando Koch of Macau Radiological Technologists Association, MRTA.
Hello, good afternoon, everyone. I am Fernando from Macau. Thank you.
We have the President of Vietnam Association of Radiological Technologists, VART, President Thai Van Lo.
Hello everyone. Hello all friends. Thank you, Palestine. Thank you.
Okay, and we have attending for Singapore Society of Radiographers, SSR, President Denise Chung is the Vice President Haris Abdul Razak. Is he here now? We have received greetings from President of Perhimpunan Radiographer Indonesia, Indonesian Society of Radiographers, or PARI, Dr. Giek Sugianto. We also have received greetings from Hong Kong Radiographers Association, HKRA. Oh, we have here the President of Hong Kong Radiographers Association. Let us greet and welcome President Mr. Nang Tat Ming.
Hi, everyone. Good afternoon. Welcome to the 41st CPD Asia. Enjoy.
And we have received greetings from Taiwan Association of Medical Radiation Technologies, TAMRT, the President Chun Yuan too. We have also received greetings from President Sophie Lee of the Association Cambodian of Radiologic Technologists, from President of Philippine Association of Radiologic Technologists, Mr. Ruben Lorenzo, from Indian Society of Radiographers Technologists, ISRT President Mr. Mohan Lal Bagwat. We also have received greetings from President Sawal Said of Malaysian Society of Radiographers, and also from President Vitrana Gamij Wimalasena of Society of Radiological Technologists, Sri Lanka. And of course, we have received the greetings from the Japan Association of Radiological Technologists, JRT President, Mr. Katsuhiko Ueda. We also have here joining us are our invited panelists. We have Mrs. Chan Lai Kwan from Malaysia.
Yeah.
Hi,
Putu Irma from
everybody.
Indonesia.
Welcome, Palestinians, for the first time. Thank you, PG. See all of you again.
Yes, and we have MRTA Chair Cora Nam. Yes, and
Hello, nice to meet you. Hello.
and Mr. Chin Chun Chu of Macau also. So thank you very much. Before we start, may I humbly request to please open your
PG,
camera for
hello,
a short
PG,
photo
PG.
opportunity. Oh,
Hello,
yes,
PG.
sorry. So we have now President of Perhimpunan Radiografer Indonesia, Indonesian Society of Radiographers, President Sugianto.
Yeah, hello everyone. PG.
Good afternoon there in Indonesia. And we also have Vice President Nelson Wan from Hong Kong.
Hello, everyone. Nice to meet you.
So before we start, may I humbly request everyone to please open shortly your camera for a short photo opportunity. All right, thank you very much, presidents, officers, and our panelists. They will be joining us again later during the Q&A session. So beginning the session now, let me call in our session moderator, Dr. Maysara Ruman. He's the CEO of the Academic Advisory Board of the Palestinian Association of Medical Radiation Technologists. So again, please welcome now the session moderator, Dr. Maysara Ruman. Is he here now? All right, so while we are still waiting, I would like to introduce that the Palestinian Association of Medical Radiation Technologists have selected distinguished. We will have speakers, Dr. Hussein Al-Masri. We will also have speakers, Mr. Afed Al-Haj Yusuf, and Mr. Surjo G.S. Suboj. They will talk about radionuclide therapy, pediatric CT. So IT team, can you please start rolling their video presentations?
Mute microphone. You mute microphone.
We'd like to know from President Muhammad Abdul Ghani, from your end, do you have a moderator, Dr. Maysara Ruman? Oh, okay. All right.
Hello, everyone. It's a pleasure to be here again. Last year, I made a presentation for Asia CPD 2023, and this year I'm also participating, and I will be showing a brief description about the establishment of the Academic Advisory Board, which was established under the umbrella of Palestinian Association of Medical Radiation Technologists. So what is the Academic Advisory Board? So it was established under the umbrella of Palestinian Association of Radiation Medical Technologists to organize scientific, technical, and training activities. The AAB aids in developing the field of medical imaging and raising the level of professional practice in Palestine. What is our mission? To promote the highest standards of quality and professionalism in medical imaging, and to develop scientific and technical knowledge. Also, to spread the culture of scientific research within the Palestinian community, and to deepen the communication and cooperation between the members of the association and the students and the community at the local and the international levels. The vision of the AAB is to enhance professional and scientific excellence in the field of medical imaging. We want to raise our level, so we also want to develop a strong knowledge community which contributes to the development and investment in the field for the benefit of health and the well-being of patients. Our objectives include supporting, facilitating, and disseminating scientific research in the fields of patient safety, radiation protection, professional practice. Also, we are developing educational materials, unifying them to promote patient-centered patient safety, patient-centered care, and patient safety with radiation protection. The communication is very important between the members of the society and the students and the community. Therefore, we want to provide communication platform for those interested in the field of medical imaging as diagnostics and also in radiation therapy educators and students. Additionally, as part of the CPD, continuous professional development, we want to develop continuous education platform to help raise the level of healthcare in Palestine. We also help in organizing and coordinating scientific and technical activities within the community. We enhance communication and exchange of knowledge between those interested in the field of medical imaging. We provide support and guidance for new members, and we promote continuous education. We strive for cooperating with local and international committees concerned with scientific research to help achieve the objectives and the goals of Palestinian Association of Medical Radiation Technologists. Of course, we need to follow up and develop the membership examination system for newcomers or new medical imaging specialists. Among our activities and programs, we organize seminars and conferences. We will take responsibility for organizing the tasks related to scientific committees and coordination of seminars. Regarding training courses, we provide ongoing training programs and sessions for members and interested members in the field to enhance their skills and scientific research capabilities. Additionally, we encourage the conduct of scientific research and provide support and assistance to interested members. Here, I give a glance for the board members, starting with Dr. Ahmed Abu Arra. He is the chair of Academic Advisory Board. Myself as the vice chair of the AAB. Then Mr. Maysar Rumman, he is the CEO, followed by 4 members of the AAB, which include Dr. Ali Abu Arra, Dr. Yasser Al-Ajrami, Mr. Firas Al-Fuhaili, and Mr. Zahi Huwari. So we represent the Academic Advisory Board of the Palestinian Association of Medical Radiation Technologists. As part of the continuous professional development, we want to have an ongoing professional activity in which radiographers identify, undertake, and evaluate learning appropriate to the maintenance and development of the highest standards in practice. Also, Palestine is a member of the ISRRT. Therefore, we want to help professionals undertake a systematic approach and follow those regulations to be able to be advanced in the continuous educational or professional development. One achievement of the AAB, which is a recent achievement, is the preparation of membership exam guidelines for 2024. It was prepared by the Academic Advisory Board, and as you can see, we systemized the membership exam, so it includes now a list of subjects related to the examination with related weights, with a total of 100%. Regarding scientific research activity of the AAB, we launched widespread survey which targets radiographers, medical imaging technologists, and radiography students also. Regarding research interests among Palestinian radiographers and students, and also to check for strategies which improve research quality and production among Palestinian radiographers or medical imaging technologists. In addition to that, as part of the ISRRT, I represent the Palestinian Association of Medical Radiation Technologists in the IAN, or International Academic Network, which is part of the ISRRT. So it also adds to the continuous professional development of the Palestinian community of radiographers. Here, I give also a description about the use of healthcare simulation software in radiography and radiation safety or protection. Recently, and after a joint cooperation between the Medical Imaging Department at Al-Quds University and the Palestinian Association of Medical Radiation Technologists, we have started to use healthcare simulation software in education. The software was provided by the virtual medical coaching company, and it can be seen from the pictures here that this is an important part of education, both didactic and professional education for students, especially in circumstances such as Corona or recent due to the blockage and in which students cannot reach the university. So this is also an important part of education, is to use healthcare simulation software. I want to acknowledge Dr. Christina from the University of London and Dr. James, he's the CEO and founder of VMC company, for providing us with this software. Lastly, thank you so much for your attention, and you can reach us on the following website, AAB members, and also if you want to have a look at the PAMRT membership exam through this the other website. Thank you so much.
Assalamu alaikum wa rahmatullahi wa barakatuh. Dear all, this is Dr. Muntasir Said Ahmad from Palestine, Hebron. Today I am appreciated to present my topic, which is organized by Palestinian Associated Medical Imaging Technologies. And today we will discuss a new topic under the titles radionuclide therapy with lutetium 177 PSMA for the prostate cancer. Again, this is Dr. Muntasir Said Ahmad. I am assistant professor in one Palestinian university called Palestine Ahliya University, which is located in the Bethlehem. And also, I am a headmaster of the medical physicist in the nuclear medicine department at Al Ahli Hospitals, which is located also in Hebron, Palestine. And I'm appreciated to share this presentation with you. Our objective in this presentation started with an introduction to the prostate cancer, then how can diagnose the prostate cancer. After that, we will see the stage of the prostate cancer, screening of the prostate cancer, how lutetium 177 PSMA procedures to treat the prostate cancer. And finally, presented some cases from our department, which is treated by lutetium PSMA. So, first of all, as we know, that the prostate cancer is the second type of the most common cancers and the fifth leading cause of the death in the men in the whole world. Early detection and accurate staging is very critical. So the prostate cancer survival rate will increasing if you detect the cancer in the early stage. And the risk factors of the prostate cancers associated with the age, family history, and the genetic mutation. There is too many diagnostic technologies using to detect the prostate cancer and to prognose if the prostate cancer exists in the patients or not. The diagnosis of the prostate cancers, it can be in different techniques. The first one, we using the serum PSA, and second, digital rectal examination. Third, the transrectal ultrasound. Fourth, color flow Doppler. Fifth is the MRI. Sixth is the CT scan. We can also using the bone scan to detect the prostate cancer, especially in the metastasis cases. And finally, we using the PET scan, CT scan, which is the more appropriate technique to diagnosing the prostate cancer. Here we can say that some of the diagnosis procedures, the first one is the digital rectal examination, PSA. The PSA give the doctors some indication about the prostate cancer. If the PSA level from 0 to 2 nanogram per ml, the appropriate or the probability to prostate cancers for those patients less than 1%. If it's from 2 to 4 nanogram per ml, 15% of the patients would have the prostate cancer. 4 to 10 nanograms, 25%. And over the 10 nanogram per ml, more than 50% of patients have the prostate cancer. So it gives the doctors that indication if the patients have the prostate cancer or not. The final or the last image is the transrectal ultrasound. According to the staging of the prostate cancer, there are 4 different stages. The first one, which is the tumor localized in the prostate and prostate gland and didn't metastasis for the other anatomical region. The stage 2, it's located in the prostate cancer, but it also affected for the seminal vessels. The stage 3, it's metastatic to the seminal vessels and enter the seminal vessels. And the 4th stage, metastatic to the lymphatic node. For prostate cancer, the stage 1 almost diagnosed with 27%. Stage 2, 56 of patients diagnosed in this stage, and it is the highest stage which is diagnosed. 3rd stage, around 8.7%, and the 4th stage, mostly 7.6% of the patients can be detected in this stage. So the screening of the prostate cancers, it's different from one lecture to the another. There are too many models or modality can be used to the screening the prostate cancer. The most famous is the MRI spectroscopy imaging and the PSMA PET scan. The first image here, it's the MRI, which just a pelvic MRI shows that there are prostate cancer in the prostate localizers and the prostate gland. The second is using the spectroscopic image, which has different the choline and the citric acid concentration. The normal patients, choline peak, it is too small comparing to the CI peak, while the prostatic cancer peak in the different stage, the choline peak is very high, while the CI peak is very low. And finally, the PSMA PET, which is the most modality using in these days to detect the staging of the prostatic cancer. What is the PET? As we know, that PET injected by the radioactive materials to the patients, and after injection, just waiting from 45 to 60 minutes, then the image of the patients will take from 15 to 20 minutes for acquisition of the image. We're using the term called the theranostic. Theranostic, exactly, it's two parts. The first word related to the therapeutic, and the second word is the diagnostic. So theranostic is come from therapy and the diagnostic. This concept actually targeted the cancer cells, where the cancer cells of the prostate cells, as we shown in the first figure, have specific receptors. These specific receptors, when using one type of the radionuclide, have the same receptors as we see in the second figure. So when you're using the radioactive materials, just combined with the receptors in the prostatic cancer, which is the PSMA, which the name of the procedures comes from. Then all of the cells, which is cancer, will take this radioactive material. Some of the cases that the receptors called the BSA, which is located in the prostatic cells. However, in the metastatic cancer from prostate, it's deviated in the whole body. So any lesions, as seen in the PET image, any lesions which have the high BSA receptors will collect this type of the material, and from them we can use the lutetium to trapping with this tracer. So the lutetium PSMA can just goes to the cells, which is affected from the prostatic cancer, and lutetium, as we will discuss later, that's containing some properties to destruct these type of the cancer. So why lutetium? Why we using lutetium, not other radionuclide? The first, that lutetium has a beta emitter, which is just transfer and penetrating the soft tissue only around 0.7 millimeter. And second thing, that the lutetium has a physical half-life around 6.7 days. So we can transfer the lutetium from different countries, and we can use it as a theranostic because it is emitting beta with small range in the human. So after the collected the PSMA, which is labeled with the lutetium to the PSA receptor, it will destruct the cancer tissue. So there is different investigations using the PSMA theranostic over the times. It started from 2014 until now. Actually, there are too many studies using the PSMA lutetium for treatment the prostatic cancers. For example, in 2016, there are more than 4 studies using the lutetium PSMA to treat more than 130 patients. And for example, in the 2018, there is important studies to using the prostatic lutetium PSMA to treat the cancer again, until reached to the official years, which is using the PSMA lutetium as the good treatment for the prostatic cancer. For example, there are this is a study which is just conducted in the 2018. Professor Michael and his colleagues working on the 30 patients who have prostatic cancer after selection from the PET using the PET CT, and those all of patients, around 87 of them receiving at least one line of the chemotherapy, 80% docetaxel and 47% of cabazitaxel. 83% of the patients receiving one acetate and the ismethylene, or both of them. After treated by using these chemotherapy materials, the patients goes to receive the 4 cycles of the intravenous lutetium PSMA every 6 weeks, and between 2 cycles, just we follow the patients with PET PSMA, and we will mention as mentioned after this. So this study just shows that the prostatic cancers, the red dots concerning of the PSM, the cancer cell metastatic. So in the first 2 figures, we can see that the patients before treated the PSMA lutetium, there are many dots around the aortic and para-aortic lymph node with the PSA more than 15. After that, treated with the lutetium PSMA, the patients PSA it was less than 0.01, and all of the dots in the red, it's disappeared, and this is the efficiency of the lutetium PSMA treatment. In the second, the PSA around 967, it reached to 7 after that treated with the lutetium PSMA. Also, all of the red dots, it's disappeared. the third figures, and all of the figures shows the same concept, that the metastatic cancers it's treated with the lutetium PSMA, and the PSA it dropped to the less than 10 nanogram per ml. The results of and conclusion for this study shows that the 57% of the patients achieved with the PSA, which is declined to less than 50% or more. So in this figure, as we see that the red colors shows that the PSA is less than 30, yellow colors from 30 to 50%, and in the blue color more than 50%. So most of the patients has the drop of the PSA as seen in the blue colors. According to the red colors, which is reagent, some patients, as all of the treated, cannot be treated also in by using the PSMA lutetium. So the lutetium PSMA has a high response rate, low toxic effects, reduction in the bony pains, and the most important things for the lutetium PSMA, how can select the patients? First of all, there are different types of the patients which is affected or just have a cancer of the prostatic cancer. Some of them has a low PSMA uptake, as seen in the figure A. So to collect or to select the patient for treating by PSMA, they should do the PET scan by FDG and the PET scan by PSMA. This is the first trial when the PSMA lutetium treatment is developed. So if their low uptake is from FDG and PSMA, these patients will ineligible to underwent the lutetium PSMA treatment. If the patient has a discordant disease, the meaning of the discordant disease that the PSMA PSMA PET has a significant or has a high SUV while the FDG is low. Also, those patients has low response to the PSMA. However, when the PSMA PET and the FDG PET have the high SU value for all the metastatic cells, these patients eligible to treated by the lutetium PSMA, and as seen in the figure 3 and the figure 4, that the PSMA and FDG, both of them have the high SUV value, and this is the suitable persons and suitable patients to treat with the lutetium PSMA. How we do the lutetium PSMA? Actually, there are 3 steps. The first step is a pre-treatment assessment, which is mainly using PSA level and make the PET scan FDG, PET scan PSMA, and selected the suitable patients to receive this type of the treatment. Also, there are the procedures in day of the procedures and post procedures. So pre-treatment again, the patients with the metastatic castrations, resistant prostate cancer, post new generations, undergone chemotherapy, imaging, making the PSMA PET scan, actually gallium-68 using combined with the PSMA, or fluorine-18 combined with the PSMA. So then we can using the select the patients. Also, the laboratory should be which adequate bone marrow and renal hepatic function should all of them using by should be laboratory before we treated the patient. Here we can see in this figure, actually this is a study just conducted in the 2019 to show that the persons who treated by the lutetium PSMA, how the treatment affected those patients. For the as we see in the figure C, there is a high PSMA average and a high PSMA range for this patients can be treated, and the overall survival reached to 21 months. While in the figure D, which shows that high PSMA average and low PSMA minimum, the overall survival reached to 11.4. And in the figure E, which has the low PSMA average and low PSMA minimum, the overall survival reached to the 5 months only. So it's very important to select the patients who can undergo this type of lutetium, and the selections just goes from oncologist and the nuclear medicine specialist. Here is the software which can be used to predict the overall survival. There are many parameters should be written to predict the overall survival, which is the time since diagnosed from after diagnosed prostate cancer to treated with the lutetium PSMA, how much the hemoglobin, how much the SUV max, the tumor SUV max, which is predicted by the PSMA PET scan, number of the metastatic, if it's more than 20 or less than 20, if there are pelvic lymph node involved or not, bone metastasis or not, liver metastasis or not. After filling these parameters, the second graph shows the overall survival. So for example, if we using the parameters as shown in the figure, the overall survival reached to 12 months with response probability reached to 97%. So this software can help the nuclear medicine specialist to diagnose and to predict the response of the PSMA for the patients. So in the procedures days, the patients should be hydrated 2 hours before the injection and 2 hours after the injection. Injected almost 150 to 200 millicurie for lutetium PSMA, and but it was injected by the intravenous infusion for 1 liter with using the amino acid just to release the and to decrease the dose in the urinary bladder. Whole body gamma ray should be confirmed after the lutetium PSMA, actually after 24 hours from the injection. Why? Because the lutetium itself, even it just emitted the beta radiation to treat, it will also emit the gamma ray with 17%. So just this, the gamma ray examination whole body should be taken after the injection for the lutetium PSMA by using the gamma camera with the intermediate collimator energy. Patient discharge can discharge after 4 to 6 hours after the injection, whenever the dose less than 25 microsieverts per hour after a distance 1 meter from the patients. And after the post procedures, just we concern the radiation safety. The patient should be hydrated, and also he or she just he should be away from the companions from 1 to 2 hours, and every day 2 to 3 days only. For the first 4 days, stay away from the children and pregnant women. Also restricted contact with the adults with maximum 6 hours per day after close contact more than 1 meter, 1 to 2 meters. Follow up, the patient goes to the oncologist after finishing with the nuclear medicine and treated with the lutetium PSMA, because the oncologist he has observed and follows the patients. The real case in our clinic, here was a 74 years old man with metastatic prostate cancer. When we do the PSMA, gallium PSMA 68 PET scan, we can see there are metastatic in whole body with the SUV is very high. So we can select this patient to treated by the lutetium. After giving the injection lutetium PSMA, we making the gamma camera whole body just to know that the high PSA lesions receive this treatment, as we can see in here in the armpit lymph node in the left side. It's the same locations in the whole body, and the PET scan the same. So post the dose assessments from 2 cycles, we give the patients 2 cycles, and after that, just we can make the post dose assessment. We can see this figure. Most of the metastatic bone in the first image is treated by the lutetium PSMA. Okay, here the second patients have a high metastatic, wide metastatic in the lumbar region, and the FDG shows that high PSA with the metastatic. Then after giving the 2 cycles of the lutetium PSMA, most of the metastatic lesions was treated. Also, the PSA levels dropped from 283 to 19 nanogram per ml. Here, another patient, the same, have when we're making the pre-dose assessments, we see that high level PSA and high SUV max in the using the PSMA gallium. After the treated, most of the lesions was treated, and the PSA level dropped from 350 to 6 nanogram per ml. The case 3 just shows that the gallium PSMA PET scans shows different locations of the metastatic lesion, and here in the CT shows that the sclerotic lesions goes to the ribs in the left and the right side. After treated, most of the lesions was treated, and the PSA level dropped from 850 nanograms per ml to 206. So in the conclusion, the lutetium PSMA, it's very effective treated to the prostate cancer, mainly in the stage 3 and stage 4, low toxicity profile, and improve the bony pains and quality of the life, as we mentioned before. If there is any questions, please ask. Thank you for listening.
Assalamu alaikum. My name is Abitan Al-Haj Youssef, a master's student studying CT and MRI sciences at AAUP, as well as a lab technician in medical imaging department. Actually, I'm so delighted to be a part of this CPD Asia event, where I will be giving a presentation on the evaluation of pediatric abdominal trauma using CT scan. This lecture includes an introduction about pediatric abdominal trauma, the diagnostic modalities the diagnostic imaging modalities that used for abdominal region, such as CT and ultrasound, the advantages and the limitations, types of abdominal injuries such as hepatic, splenic, renal, pancreatic, the detection and the quantification of active hemorrhage, bowel injury, and bladder injury, and also the impact of CT findings on clinical decision making, and finally CT dose reduction strategies, since radiation dose is a major concern, especially for pediatric. Trauma is a leading cause of morbidity and mortality for pediatric. For example, every year in the United States, there is 1.5 million pediatric injuries, 50,000 hospital admissions, 20,000 death cases. Approximately 80% of these injuries are due to blunt force trauma. The abdomen is the second most common site of injury, and the most common mechanism of injury is motor vehicle crashes. And it's essential to consider the important physiological differences between pediatric and adult after abdominal trauma, so the clinical evaluation of pediatric is a difficult and challenging task. The abdominal trauma is typically categorized by the mechanism of injury into two categories: blunt trauma and penetrating trauma. While blunt trauma may involve a direct blow such as kicking, impact with an object such as fall on bicycle handlebars, or sudden declaration such as falling from a height. And spleen is the major organ that most commonly to be damaged due to this type of trauma. While penetrating trauma caused by metal or wooden piece which penetrate the abdominal region may or not penetrate the peritoneum, may or not causing organ injury. The management of abdominal trauma differs from one organization to another according to the used protocol at each institution. Here an example about the management of blunt abdominal trauma, which used at Children's Hospital of Pittsburgh, Pennsylvania at United States. First of all, the trauma itself should be surveyed into primary and secondary with appropriate resuscitation. If the patient is hemodynamically unstable, the patient should be transformed directly to the emergent laparotomy. While if the patient is hemodynamically stable, so that abdominal examination should be performed. And according to the physical examination, if there is no abdominal wall markings, so that several laboratory tests should be performed and the results should be checked, such as AST, ALT. If the results were normal, so that the decision of discharge or hospitalization based on the severity of mechanism or presence of associated injuries. While if the results of those laboratory tests were abnormal, so the patient directly transferred to perform abdominal CT scan. While if the physical examination shows lap-belt ecchymosis, so that the patient should be transferred to perform abdominal CT scan. According to the abdominal CT scan finding, the medical team will select laparotomy or non-operative management tract. Physical examination or laboratory findings are the indications for abdominal imaging, such as hematuria, which is the most common indication for abdominal imaging, abdominal ecchymosis, abdominal distension, abdominal pain, vomiting, and blood from the rectum or nasopharyngeal tube aspirate. Sonography is one of the most common techniques used in imaging abdominal region after trauma. While sonography has limited utility in the assessment of pediatric abdominal trauma, it has been primarily used in the detection of hemiperitoneum in traumatic patients. However, the presence of hemiperitoneum in the hemodynamically stable children typically has limited impact on the management decisions. Also, the sonography techniques shows variable sensitivity and specificity in the detection of hemoperitoneum. Also, it does not provide any diagnostic information for pelvis or lumbar spine, which can be associated with abdominal trauma, and it also has been shown to miss 1/4 to 1/3 of solid viscous injuries. So these are the limitations of using sonography for abdominal scanning. The primary sonographic technique used for the evaluation of abdominal trauma has been described as focused abdominal sonography for trauma, FAST technique. It's a fast and non-invasive technique used for evaluation right upper quadrant, left upper quadrant, and pelvis region, just only for free peritoneal fluid. While CT scan is the gold standard method for evaluation abdominal traumatic cases for several reasons, such as it allows accurate detection and grading of injuries to solid and hollow viscera, identifies and qualifies intra and extra peritoneal fluid and blood, and it also has a major role in detecting and quantification the active bleeding. It also shows the associated bone injury to ribs, spine, and pelvis, and can help prioritize optimal management by diagnosing the most life-threatening site of injury or hemorrhage. Also provide multiplanar and 3D reformatted images. All of these make CT scan is the gold standard for evaluating the abdominal traumatic cases. There are several differences between the pediatric abdominal CT scan protocol and the adult protocol. According to patient position, the patient should be supine, feet first, and the patient should be centered within the gantry in order to use the automatic exposure control efficiently, which is used in order to reduce the radiation dose to the patient. It's a common practice for non-cooperative pediatric to use variable types of motion restriction devices, such as patient safety straps. And according to the sedation concept, it's rarely to use sedation before the CT scan examination because of the advances of CT technologies, which has greatly reduced the scanning time, which also reduces and limits the possibility of motion artifacts. According to scanning range, the scanning range should be limited to the area of interest based on the clinical indications, while it's typically for abdominal scanning, it ranging from diaphragm to pubic symphysis. And the patient should be instructed to hold the breath at the end of inspiration, and the use of IV contrast by rapid bolus injection is essential in order to maximize the opacification of solid viscera and also to ensure adequate injury detection. 2 ml per kg with maximum amount 120 ml with a flow rate 2.5 ml per second. And there is controversy regarding to the use of oral contrast material after trauma. There is potential advantages and disadvantages. The advantages of using oral contrast is to enhance the detection of a small intramural or mesenteric hematoma, and also to improve the delineation of the pancreas from surrounding bowel, and finally to detect the oral contrast extravasation as a sign of bowel rupture. While the potential disadvantage include time constraints and decreased bowel motility in the traumatic pediatric. Also, the rectal contrast media can be used, which based on the clinical indication of each or of the case. In trauma setting, techniques differ from institution to another according to facilities, indications, and guidelines, and CT protocols should be tailored to match the need of each individual patient. According to the scanning phase series, most of institutions depend on portovenous phase 75 to 80 seconds after administration of contrast media in diagnosis. Examples of pediatric abdominal trauma is hepatic injury, which is the most common or the second most common injured organ. And CT findings of hepatic injury can appear as laceration, hematoma, parenchymal or subcapsular, or both of them, while the vascular injury for the liver due to trauma is rarely to be occurred in pediatric. This table describes the liver injury grading according to injury description from the 1st grade to 6th grade in concepts of hematoma and laceration. For example, the 1st grade hematoma, subcapsular, non-expanding and less than 10 cm surface area, while laceration, capsular tear, non-bleeding and less than 1 cm parenchymal bleeding, while the 6th grade, which is vascular injury, and we said that it's rarely to be occurred in pediatric, while the description of the injury is vascular avulsion. Those are images which presenting the appearance of hepatic injury due to abdominal trauma. The right-sided image, it's a coronary formatted CT image showing the complex hepatic laceration, while the left-sided image showing the laceration extending in the periphery of liver with associated subcapsular hematoma. And this image showing the vascular injury of the liver presented by the absence of contrast enhancement in the posterior segment of the right hepatic lobe. Splenic injury is the most common injury after blunt trauma. CT findings will be laceration with variable appearance from linear to branching pattern. And since the spleen is smaller than liver, so shattering and or fragmentation can be appeared on the images, which associated with intraparenchymal or subcapsular hematoma. The right-sided image, it's for 12-year-old boy with splenic laceration and intraparenchymal hematoma, while the left-sided image for 14-year-old boy showing the shattered spleen. The renal injury is the third most common injured abdominal organ, either the injury in the renal parenchyma due to direct impact, or vascular and collecting system due to sudden declaration, and the renal injury can be complicated by perirenal hematoma, subcapsular or perinephric. The right-sided image showing the subcapsular renal hematoma for 12 years old compressing the renal parenchyma, while the left-sided image, it's for 14-year-old boy, the injury in the collecting system, renal collecting system, delayed phase, showing the extravasation of contrast media in the perirenal space. And this image, it's a coronal reformatted image showing the segmental renal infarct, multiple peripheral wedge-shaped renal parenchymal defect. Pancreatic injury is rarely to be occurred in pediatric, and there is no direct sign for injury or difficult to be detected due to pancreatic small size, and it's also surrounded by fat. It can appear as focal or diffuse gland enlargement extending from peripancreatic or mesenteric fat, and can be complicated to fluid collections, which called pancreatic pseudocysts. This image for 10-year-old girl with pancreatic injury with associated fluid collection surrounding the pancreas. The impact of CT findings on clinical decision making. We said that CT scan has a major role in detecting the absence or presence of visceral and bone injury. So, according to the CT findings, the medical team will require close monitoring or operative intervention, and it also has a major role in detecting and quantification the active hemorrhage. So we can say that for patients who is hemodynamically stable, CT scan has a critical role in the success of treatment management. While for patient who is hemodynamically unstable, the decision for operation intervention based on the clinical criteria, not on CT findings, since the patient is urgently transferred to the emergent laparotomy department. CT dose reduction strategies. The major strategy to reduce the radiation dose from the CT examination is the reduction of utility of CT examination. Since the radiation exposure is a major concern, especially for pediatrics, since pediatric is more sensitive to radiation than the adult. So the medical staff should make a balance between the medical benefit and the radiation risk from the CT examination for the pediatric patient. So if the medical team select the CT examination for diagnosis and for management and to take a decision about the management, so that the role for CT technologists to make several strategies in order to reduce the CT dose from the performed examination. For example, the CT technologist should select the pediatric protocol, not the adult protocol, since the scanning parameter in pediatric protocol are totally different from the scanning parameter for adult protocol. This is the first one. And the second thing, the scanning range should be limited to the area of interest in order to reduce the radiation, unnecessary radiation to the patient. And this will be according to the medical needs and also to clinical indications and considerations. And also the series of the scan number of phases should be limited according to the medical needs. Here a table showing the estimated effective dose for the typical pediatric CT examination, such as brain, chest, abdomen, and pelvis, according to the age group, and also according to the ICRP report 60 and ICRP report 103. We notice that the effective dose from abdomen pelvis CT scan ranging from 2.5 to 10 millisieverts, and this is 3 times more than the background radiation that received by the population annually. And those are the references that used for preparing this presentation. Thank you for listening and for your time. And if you have any question, please just ask. Bye-bye.
Hello everyone, my name is Sujud Subah. I'm a lecturer at the Medical Imaging Department at Najah National University. Today I will present about low-field MRI. What is low-field MRI? Challenges, limitations, and the clinical applications of the low-field MRI. So what is low-field MRI? Low-field MRI defined as any field strength below 1.5 Tesla. However, the specific definition can vary, with some sources define low field MRI as a narrower range between 0.01 Tesla to 0.1 Tesla. For this presentation, lower field describe device below 1.5 Tesla. So, the most dominant devices in our healthcare system is the high field MRI devices. However, there is many factors drive the uses and the popularity of low field MRI. One of these factors is the lower scanner cost, which is the primary advantage of low field MRI because they are cost effective compared to high field MRI systems. The other factors that drive the use of low field MRI is technological innovation, which improve the image quality and make possible to use the low field scanner in the diagnostic range or in the diagnostic field. What are these technological innovations? These technological innovations include hardware and software. Also, they use computational power to enhance SNR and imaging. In the sections of hardware and software developments, there is improved in coil design, which include flexible and portable coils, which allow which conform to different body parts, enhancing comfort and image quality, and adaptable MRI setup, making it easier to perform scan in various settings, especially in point of care and remote locations. Also, there's development of efficient gradient system, and the gradient system is very important in MRI machines because it's very critical for spatial encoding of the MRI signal. So recent advancements have led to more efficient and powerful gradient systems that improve the overall image quality. These systems are designed to work effectively even at lower magnetic field strength, helping overcome one of the primary limitations of low field MRI, which is the low spatial resolution. Also, there is advanced software algorithm. These software algorithms optimize image acquisitions and processing. So software play a crucial role in performance of MRI systems. Advanced algorithm now optimize the entire image process from data acquisition, final image reconstruction. These algorithms can enhance signal-to-noise ratio and improve image clarity, making low-field MRI more competitive with high-field MRI. Also, there is the use of computational power to enhance SNR and image quality. So these advanced like noise reduction technique improve SNR. Also, the utilizations of deep learning and artificial intelligence to the system, which improve the high quality image reconstructions. There is also a real-time processing capability, which help in immediate image reconstruction and analysis. This capability is essential in a clinical setting where timely diagnostic is critical. Real-time processing made possible through advanced in computational power, enabling quick and efficient handling of complex data generated by image scan. This improving enhance the workflow efficiency and patient care. Here we will present some example of the image reconstructions technique used on lower field scanner and even in the higher field scanner. One of these are the automap, automated transformed by manifold approximations. What is this technique? This technique is based on the machine learning. So there is the neural network, which is trained on large data set of MRI scan, learning to recognize pattern and feature in the raw data. So when these neural network are trained, the network can quickly and accurately reconstruct image from a new raw data, often outperforming traditional reconstruction methods, which provide higher image quality with less noise and less artifact, and reduce the need time for manual cutting and reconstruction parameter. The other example or the other technique we can use is the MRI fingerprinting. What is MRI fingerprinting? So during the scan, usually there's a unique signature or fingerprint is generated for each type of tissue based on their relaxation time and different parameters. So this fingerprint, usually when the scan is done is taken and compared to pre-computed dictionary to identify and quantify the tissue properties. So there is many advantage of this technique, which is enable which enables simulus multiparametric imaging, provide comprehensive tissue characteristics. Also can significantly speed up the image processing while maintaining high accuracy to the image. Another example is compressed sensing. Compressed sensing describe a technique that used to reconstruct the imaging from undersampling data. So instead of acquiring all the data needed for a full resolution imaging, compressed sensing acquire a subset of the data and use mathematical algorithm to reconstruct the full imaging. This approach helps in reducing the number of measurements required, thus decreasing the scan time. So we have shortened the scan time, improved patients' comfort, and maintained the image quality despite the reduction in the acquisition time. The final example we will talk about today is deep learning-based super resolutions. So deep learning-based super resolutions, this technique is based on using of deep learning algorithm to enhance the resolutions of MRI imaging. So the deep learning model, usually in this technique, is trained to recognize high frequency detail and picture in high resolution image. And when this algorithm is applied to a low resolution image, the model can infer and adapt these details effectively in increasing the resolutions of the image without increasing the scan time. And also that's helped to provide a diagnostic quality image from data accurate at lower resolution, making very useful for low field MRI system. Okay, as you can see in this image represents different or the most used MRI sequence produced in everyday clinical applications, accurate by 0.55 Tesla. As you can see, the image quality in these are high. There are diagnostic image. You can't tell the difference between this image and the image accurate at 1.5 Tesla, for example. But if we go higher magnetic field, like 3 Tesla or higher 7 Tesla, you can tell the difference. There's more signal in this image compared to 1.5 Tesla, but still these images are diagnostic and can give accurate diagnostic. The clinical applications can be used in low field. So there's different application can use in low field MRI. We can image any body part using this scanner, but there's a specific clinical applications for low field MRI, which are the for brain imaging. So portable MRI system can be used in intensive care unit to image patients who have suffered from stroke or other acute neurological conditions, which are timely diagnostic. So using this portable system can eliminate the need to transport critically ill patients to the radiology department, thus reducing the risk associated with moving patients, and can help with continuous monitoring of these patients. So this portable scan allow for continuous monitoring and frequent imaging as required, providing real-time information about the patient's conditions and response to treatment. Also can help with outpatient neuroimaging. So low-field MRI increasingly being used for outpatient neuroimaging, particularly for chronic conditions like multiple sclerosis and hydrocephalus, which help with frequent imaging and continuous monitoring for these disease, and it's more patient convenience. Also, it's used for MRI-guided procedure and for intervention in radiology. So mid and low field MRI system are used during surgical procedure to provide real-time imaging wideness. And for low field MRI system, we don't see that much of heating increase during the procedure. So it's possible to use needle with different length, insertions, diameter, without worrying about how much heating we will get from these insertions. Finally, it will be helpful also in pediatric imaging because low field MRI system, especially this system with open design, can reduce noise level and are high beneficial for imaging pediatric patients. If we use low-field MRI scanner design, open design with reduced noise level algorithm, that can be used for pediatric imaging and can be child-friendly design and can be reduced the need for sedations and the associated risk with these sedations. Okay. Okay, here an image for a brain, for a patient with a brain neurological disorder, with the neurological disorder, which images and using 3 Tesla MRI fields, scanner strength, and also image using 0.064 Tesla. Yeah, there's a difference, absolutely there's a difference in image quality. 3 Tesla show a higher signal intensity, but still, this usually this field strength can be used as a portable imaging, so we can use it in the ICU unit to monitoring the patient's treatment, response to treatment, or real-time monitoring for the patients. Also here, an image show catheterizations or wideness for catheter during a procedure in the MRI using 0.55 Tesla. This image show example of using low field MRI scanner for musculoskeletal imaging, as you can see. The final one is for the lung imaging using 0.55 Tesla and 1.5 Tesla. As you can see, 0.55 Tesla produce a higher signal intensity compared to 1.5 Tesla. And this due to the fact that 0.55 Tesla have more homogeneous field. So higher field also, one of the limitations of problem with high field strength is the inhomogeneity of the field and the artifact associated with this. So 0.55 Tesla have more homogeneous field, so less artifact, especially in the lung, and we can get more detailed imaging. And this because and this is why they use during COVID-19 to monitoring a lot of patients who have or diagnosed with COVID. The final image here show a real-time heating produced by 1.5 Tesla and 0.55 Tesla for guide wire insertions. As you can see, the red line represents 1.5 Tesla, while the blue line represents 0.55 Tesla. 0.55 Tesla doesn't show any heating, any significant heat increase, while the 1.5 Tesla show a really significant increase in heating. So you can, it's really safer and easier to use 0.55 Tesla for image wideness during the interventional procedure. So challenging and considerations when we talk about low field lower SNR and resolution. So low-field MRI inherently have lower signal-to-noise ratio and reduced resolution compared to high-field system. This is due to the weaker magnetic field strength, which will produce a weaker signal from the tissue being imaged. Lower SNR can result in images that are less clear, making it more challenging to find details, which critical for accurate diagnostic. But the innovations of the technology innovations and innovations of machine learning and mathematical algorithm help in overcome this problem and increase the image quality, reduce the noise, reduce and increase spatial resolutions. This technique like deep learning reconstruction, sequence optimizations, and high reliability contrast agents. On the other hand, cost and accessibility it's a primary advantage for lower field MRI. So usually lower field MRI are cheaper to manufacture and maintain. Also, it have a smaller footprint and lower power requirements. So low field MRI system typically have a smaller physical footprint and require less power to operate. This makes them suitable use in variety of clinical environment, include rural and under reserved area, which may have a smaller space and limited power supply to this area. There's also operational and practical challenges. Like we need to, before using or before going for low field MRI, we need to see if this system can be adopted in clinical practice or not. Its effectiveness must be validated for specific medical conditions and scenario. This involves conducting clinical trial and study to ensure that low-field MRI provide a reliable and accurate diagnostic information for the intended use cases such as neuroimaging, musculoskeletal, and other applications. Also, we have compatibility with existing workflow. So it's crucial to ensure that low-field MRI system can be seamlessly and easily integrated into the healthcare workflow. This means that the new system should be compatible with current hospital information system, electronic health record, and other diagnostic treatment protocols. So because any disruptions to the established workflow can lead to inefficiency and potential error in patient care. Also, one of the important issue to consider is the training radiologists and technicians. So radiologists and technicians need to be specialized training to interpret imaging produced by low-field MRI system accurately. So this should be cover the image quality, potential artifacts, specific diagnostic criteria associated with lower field strength. Without a proper training, there is a risk of missed interruptions and diagnostic error. And for low and middle countries, low and middle income country, there's special considerations like the infrastructure needed. So so the availability of technical support and service material is a major considerations in low and middle income country, ensuring there's trained technicians, spare part, and maintenance service available locally. Also, we should make sure there is valuable radiologists and technicians, because most of the low income and middle income countries are shortage of trained radiologists, which may be limitations to use low field MRI, but this can be overcome by using remote diagnostic support and telemedicine platform. Also, we can use the AI to help the radiologist and identify potential area which need to review, which reduce the time taken by radiologists to interpret the images. In conclusion, low-field MRI offers significant cost effective with lower manufacturer installations and maintenance cost compared to high field, but there's a lot of improvement need to be done, and to take into consideration the low SNR and image quality produced by this system. Also, we need to make sure the validity of this system and the compatibility of this system to our health system. Thank you for listening, and don't hesitate to ask me questions. Thank you.
Yes, thank you to our dear speakers. We would like to know if Dr. Maysara is already here, so we can start with the Q&A session. While we are waiting, we already have received 3 questions from our audiences here in Zoom. Dr. Maysara? And I hope that the microphones of our speakers are already set. We have questions here. If you'd allow me to start reading the first question. This is from Duta Kamsworo from Indonesia. This is a question regarding a diplomatic situation in Palestine. The participant would like to know, how does nuclear medicine in Palestine get the source of Lu-177 PSMA for examination in Palestinian hospitals? The participant would also like to know if there are any restrictions on which countries can send these radioactive sources, and does Palestine have its own nuclear reactor for research purposes? I think our speaker for that is Dr. Muntasser Ahmad. Are you here? While we are waiting for our speaker,
Dr. Muntasser,
again, we would like to welcome back our panelists. Yes. Yes, we would like to welcome back our presidents and our invited panelists to also join us in the Q&A session. If you have questions, you can also unmute and direct your question to our speakers. Yes, President Mohammed.
Yes, regarding this question, I don't see if Dr. Muntasser is available now, but if he isn't available, I don't see him. I
good
can
morning.
answer.
Good morning, everybody. Sorry, I was
Yes.
have a technical.
Yes, hello. Welcome, Mr.
Good.
Maysara Ruman, our session moderator. Yes, we are now having our Q&A session here.
Sorry, it was I have very technical issues. Now it's fixed. So sorry for all. Okay, let's restart. If any questions for the first session, for any question for Dr. Hussein.
Dr.
Yes.
Maysara, there is a question from Indonesia. The first question, you can check the question box.
Okay.
You can read it. I think already Bichi read the question.
Okay.
So she
All right,
asked
so,
Dr. Muntasser to answer this question. Yes, Dr. Muntasser not available now to answer this question. So regarding the answer, we haven't any creators here in Palestine, but the radionuclide are imported from another country, from Israel. There should be an arrangement between the Ministry of Health and the Minister of Health of Israel to introduce these materials before 3 weeks, I think. And all the details of the patient should be sent there to have the approval to introduce these materials.
yes, the participant is also interested in knowing if you have nuclear reactor for research purposes there in Palestine.
No, there is no reactors here now, and it is a difficult process to introduce these materials. There is a lot of restrictions due to the dangerous nature of these materials, and a lot of time and many information should be sent before make an arrangement for the exam itself or the appointment. So before 3 weeks of the appointment, there should be an request with the information of patient details, information details about the situation, and the exam should be sent there. And when they approve, they will tell the department of radiology department the time they should be come and take these materials.
Yeah, so thank you for the answers. And the second question is in the Q&A, from the Q&A box. The question says, why is the scan delay time for the children is the same as adult? And he stated here 75 seconds. So I think that's for our third speaker, Mr. Afetan J. Al-Haj Yusuf. The
Mrs.
question
Afnan,
here from
Mrs. Afitan,
from
it's available now. I think it is not available if the Zoom left the meeting.
Okay, so then perhaps I can proceed with the third question. This is again from Indonesia, and the question is, it reads, can you share your experience if there are any difficulties that you faced in Palestine being radiographers?
So it is the question for the fourth speaker, Sujud.
Oh, no, it's not, I think it's a general question. It's not specific for any of the speakers. It's just ask about the radiographer situations in Palestine. And I don't think I'm the best person to answer this question because I don't have that much on-hand experience on radiography or radiations. But of course, we have limitations. We don't have the freedom for work, learning, and do research as other radiographers around the world. Because we have limited resources in Palestine. We have like limited, let's say, educational sources because we are not allowed to travel occasionally. Because if we want to do like a workshop outside abroad, we have to do a lot of preparations. So the situations here for radiographer is of course different from other radiographer, but I don't say it's the worst because we learn how to deal with these situations to find alternative solutions, and now we are working with that. And as you can see, we think we did our best, and that's it. I don't know. I think Mr. Muhammad Abdul Ghani is the best one who can answer these questions because he already on contact and have a lot of on experience on this situation.
Thank you, Sujud. Thank you, Sujud.
Thank you.
So,
Thank you.
so
Yes.
Mr. Muhammad, could you summarize the answer for this question, please?
Yes, of course. We have here 380 checkpoints. When we want to move from city to another or from village to another, we should move 3 checkpoints that delay the when we want to reach to our work. This is the first thing, as mentioned by Dr. Sujud. We have a lot of difficulties in reach the research or learning materials due to the political situation here in Palestine. This is takes a lot of time, takes a lot of money. The financial problems here also in Palestine, everyone know it is from many of years. Not everyone can reach the learning materials due to the financial situation and the political situation. Many difficulties and obstacles which inhibits or don't let radiographers to participate in the learning or education. We need many simulation system here in Palestine because there is a shortage of simulation systems, lab of simulation. So clinical education, we have a shortage in clinical education labs here in Palestine. So we have this is due to the financial situation here in Palestine. So many difficulties, some of them due to the financial and any others for the political situation.
Thank you, Mr. Muhammad.
Thank you.
Thank you. So next question.
Hello, I have a question.
Okay.
Yeah.
Good morning.
Yeah. Hello. I want to ask, have a Dr. Hussein Al-Masri already now?
So,
The first
yes,
speaker.
I'm here.
Yes.
Yes.
Hello. Hello.
Hello.
I have a question for you.
Yes.
How in new radiographer in Palestine, who give them working license? Your society, PAMRT, or from a government?
Okay.
Radiographer.
Okay.
New
So
radiographer.
So after the students graduate from the university, they apply for the PMRT membership examination. And if they succeed, they receive a membership certificate. And then they apply to the Ministry of Health for the practitioner license. And in that case, they will get their own Ministry of Health license for practicing radiography in Palestine. So, students, or I'm sorry, graduates should first seek a membership from the Palestinian Association of the Radiologic Technologists, and then they can apply to get their license from the Palestinian government, Ministry of Health. This is the way in Palestine.
Yeah, thank you. Your second question for you. How you have a good relationship with in radiographer and radiologist society? For example, you host conference to get the radiographer and radiologist together in Palestine.
I'm sorry again. You mean if the
How
radiologist,
Yes.
or you mean radiologic technologist?
No,
Yeah,
the
radiologist.
Between radiologist and radiologic technologist. That's the question. The relationship between them.
They are not the same, of course. Radiologic technologist or radiographer society or medical radiation technologist is different from radiologist society. Those are medical practitioners originally, and then they have their own association for medical doctors. In our case, we are radiographers or medical radiation technologists, and we have our own society or association, and our internal law and bylaws are different from theirs. So we are different. Of course, the medical radiation technologist or radiographer doesn't work or get their permission from the radiologist association or society. If that makes it clear for you.
Thank you, Dr. Hussein Al-Masri. Thank you.
Thank you for questions.
Yeah, I want to talk with the second speaker. Already, Mr. Mustasir Ahmad.
Dr. Muntasir. The second speaker was Dr. Muntasir Said Ahmed.
Yeah,
We'll
say
check
hi.
his.
He already now.
Muntasir.
He already
Dr.
now.
Muntasir. I think he is not here.
Yeah, not here. Okay, sorry. Skip. And the third speaker, Mr. Fatan Yusuf. I have a one question for her.
Mrs. Afitan.
Yes,
You
hello.
already...
Okay.
Hello.
She's
Thank
here.
you.
Nice to meet with you.
Yes, thank you. Okay, congratulations in your presentation. I hear you say the US and CT scan in trauma for children of pediatrics. Usually in your hospital, in trauma, pediatric or trauma, you use US first and you miss US and CT scanner. For example, US ultrasound in US in negative. For if in clinical positive, everybody move to CT scanner. The first question for you.
So the question for Mrs. Aftab is, what's the priority for you in your hospital for trauma patient? Is it for CT directly or to use ultrasound? That was your question, Mr.
Yeah. This is your question, Mr. Thai.
Yeah.
It is the first line is CT scan or not for traumatic cases.
Yeah, ultrasound, US. Ultrasound, US.
Yeah, I said that the medical team should perform a balance between the medical benefit and the radiation risk. If the case suggests for the medical team to go to the CT scan according if the patient hemodynamically stable or hemodynamically unstable. If the patient hemodynamically stable, according to the physical examination and clinical indication, according to the physicians who examine the patient, according to these results, and also to the laboratory test AST, ALT, according to all of these findings, the medical team will refer or transfer the patient to CT scan or to other department. We said that the first strategy to reduce the radiation risk for the pediatrics, since the pediatric is more sensitive to radiation, since the lifetime for irradiation is more than the adults. So it's a special concern for pediatric for radiation protection. So that there are fast technique for ultrasound, focused time ultrasound. It's has many benefits to detect any abnormalities for each case. If it's hemodynamically unstable, the patient dynamically unstable will be transferred urgently to the emergency department. So the decision for transforming the patient to CT or ultrasound or the emergency department, referring to the medical team and the medical decision.
Thank you.
Yes.
Our roles to reduce the radiation risks if the orders will be to perform CT scan for the pediatric patients according to the scanning range, according to the scanning time, according to the number of phases, according to the clinical considerations and other techniques. But the decision for the CT transforming according to the medical team, medical staff, physicians.
Thank you, Apitan. Thank you.
Thank you. The second question. The second question for you. I saw in your presentation, you say in trauma, in your protocol, only portovenous phase. My question for you, if ultrasound have a problem in liver, you only protocol phase, protocol portovenous phase only?
So, Apitan, the question is, what's the trauma protocol specifically in pediatric trauma? Is it portovenous phase directly after the injection, or do you have arterial, or what is the benefit of ultrasound in liver injuries? That was the question. So, Ms.
The most common used phase for, I'm with you. The most benefits phases for CT abdominal pelvis CT scan for pediatric is the portovenous, but we can also perform the delay scan. Delay scan is very important for spleen, for liver, and for pancreatic.
So I will ask the question.
And the second branch of the question, what's the benefit of ultrasound?
Yeah.
What's the benefit again, please? What's the benefit of ultrasound
in liver injury?
For example, ultrasound show you, okay, have a problem. Ultrasound have a positive sign in liver. Okay, I think only portovenous phase, I think are not enough. You hear me?
Yeah.
Again, please. I have a technical problem.
Yeah, he's asking you that portovenous phase is not enough for all types of liver injuries. So if you just do the venous phase, what's the role of ultrasound in liver? liver trauma.
Yeah, guide for you. Liver have a trauma problem. I think you must enough aorta, venous, and later phase enough pre-phase.
The trauma protocol
For this case,
has
we can
phases.
Yeah, we can perform the delay phase for this case, and also the ultrasound scanning for the liver is benefits in this case also, but it's according to the grade of the liver injury.
Okay, thank you so much. Okay, the last question for speaker number 4, Mr. Sujud is support.
Sujud Subo.
Already here?
Yes, I am here.
Okay, thank you.
No
Mr. Sujud. Okay. Okay, yes. I agree with you. It's a low field MRI now, lower field now, very cheaper. But you long time, I don't remember in low field MRI a long time ago. I'm worried in quality. I'm worried in scan time for patient. How you can share your update now in low field MRI machine now have they develop in software, they develop in AI to get you can recommend for everybody in now upgrade in AI in low field MRI or software, new software or hardware now. You can say something for everybody now.
Okay. Sorry. So, yeah, low field MRI is very popular these days compared to the past. It's cheaper, of course, and more affordable, but it have many limitations and disadvantages. As you mentioned, that they have lower image quality. We have a higher scan time because of the low signal we get from the scan. But integrated AI to the machines and to the hardware make it more possible to use this scanner these days. So AI, fingerprint, automap, and compressed sensing all help in increase image resolutions, increase contrast, and of course increase SNR. Even it's now competing with the high field. When I say high field, I mean 1.5 Tesla and 3 Tesla. So integrating AI, deep learning mechanism, machine learning, all now help with the integrations of low field MRI, especially in ICU units, because ICU patients can't wait to in line or can't wait to transfer to the departments, because usually medical imaging departments is not in the ground floor. So with even in the emergency room, a low field MRI scanner, especially portable low field MRI scanner, would be more helpful. And the use of AI and AI machine learnings and deep learnings and example can enhance the image qualities and increase the image resolutions and contrast. If that answers your questions.
Thank you.
Thank you.
Okay, enough. Thank you, Mr. Rumen, thank you, Ms. Support. Thank you so much in Palestine Society.
No worries. Thank you. Thank you so much.
Thank you for
that was
participation.
so lovely. Thank you.
Thank you.
Okay. So any other question? Because we have 4 minutes left for the meeting.
Yes, I think Bichi should continue with the last session.
All right. So again, thank you to our moderator, Dr. Maysara Ruman, the CEO of the Academic Advisory Board of the Palestinian Association of Medical Radiation Technologists. We would like to say thank you to our dear presidents and to all our invited panelists. Of course, to the 4 excellent speakers from PAMRT who just gave us insightful presentations and sparked a lively Q&A. Thank you, speakers Dr. Hussein Al-Masri, Dr. Muntasser Ahmad, Mr. Afetan Al-Haj Yusuf, and to Mr. Sujud Subu. We have learned so much from your very interesting and important discussions about the AAB of the PAMRT, radionuclide therapy, pediatric CT scan, and low-field MRI. We hope to hear more lectures from you soon or next time. So yes, we are all excited about the next online CPD Asia. So to give us an invitation, please welcome to speak for SSR President Denise Chung is the Vice President. Please welcome Vice President Haris Abdul Razak of the Singapore Society of Radiographers.
Hi, hello everybody. Can everybody hear me? Yeah, okay, right. So we are going to present the next ACSPD talk, which is on the 19th of October, and the theme is on developing workforce 2030. There'll be 3 speakers from Singapore. There'll be Jasmine Lee. Jasmine is our SSR Professional Matters Chair. So she deals with everything related to professional relations, such as registration, and professional matters in general in the society. And then there's also Denise. Denise will be talking about manpower changes, manpower landscape in Singapore, as well as and to do that, she'll be looking into the literatures and looking at how other countries are managing manpower, or the issues that other countries are facing in regards to manpower. And Denise is our SSR president. And myself, I'll be talking about digital transformation and how we can use technology as a solution to manage manpower issues in that we may have in at work. Jasmine also, in her capacity as assistant manager for her hospital, she works in Khoo Teck Puat Hospital as a principal radiographer. She'll be talking about how she manages rostering and leaves, and also manpower in the department as well. So she'll definitely be able to share how she manages her and department with regards to manpower. So we're very stoked. The poster is out, but it'll be shared. I think PG will be sharing the posters soon, and basically how to register. Thank you very much.
Yes, thank you very much. You have it from the Vice President of Singapore Society of Radiographers, Vice President Haris Abdul Razak. And you have heard it right, a very interesting topic and theme, developing workforce 2030 from Singapore speakers. All right, so we will definitely save that date. So as we end, we give thanks to the support of BT Healthcare Vietnam, to all our Zoom sponsors. We thank and congratulate the CPD Asia host, President Mohammed Abdul Ghani, the President of Palestinian Association of Medical Radiation Technologists, to all your officers and to your CPD organizing committee. Also, we appreciate the ongoing cooperation from the CPD Asia IT team, to all our society's presidents, the officers, in bringing you interesting CPD Asia every month. Above all, we would like to express our gratitude to all our registered participants. And did you know that we have an average of 3,000 participants from all our available platforms? So we thank all of you, our dear audience, who always help us make this online CPD Asia program a success. We will see again next month in the next CPD Asia. Again, I am Peachy Luna, and I say thank you, everyone. Keep safe, all radiographers and radtechs in Palestine. We'll see you next time, and have a great day.
Thank you for all.
Thank you.
Thank you, Richard.
you.
Thank you for all.
Bye-bye.
Bye.